Hi, everyone. Welcome to today's live expert session on the recognition and management of dry mouth and why it matters for patients with lupus. We have Dr. Wu here to share her extensive expertise with us today, and we'll have a Q&A right after her talk. I think we'll dive right in. Dr. Wu, would you share a bit about yourself so that we can get started?
Yes, my name is Ava Wu, and I'm actually broadcasting from the Bay Area in Northern California. And it's a pleasure to be here on this special day to speak to you about the management of dry mouth. I actually am part of the Sjogren's clinic at the University of California, San Francisco, where pretty much my entire practice is seeing patients who have dry mouth. And it's usually due to patients who have an autoimmune disease known as Sjogren's disease, and a lot of them will also have lupus. And so, with that in mind, we will get started. And today we're going to focus on um, the management and also recognizing when an individual has dry mouth and what do you do. And then we have a second part of this presentation that will go on Friday, I believe around the same time, which focuses on more the caries management that is very important for individuals with dry mouth. And so with that, we will get started. Let me see, I'm trying to advance my slides. And okay, so basically, what is dry mouth? Essentially, it's an abnormal dryness of the oral cavity resulting from abnormal, and that's usually low levels of saliva. So typical symptoms are, feeling of discomfort, dryness, your mucosa sticking to each other. So when people talk, you sort of hear this characteristic clicking of the mucosa, um, sort of, you know, your cheek sticking to your teeth, your tongue sticking to the top of your mouth. And I think I mentioned the lipstick sign. So there's a lot of different symptoms that are associated with dry mouth. It's different for different people, but keeping that in mind, I think most people who have dry mouth know that they have dry mouth. So essentially, dry mouth is prevalent within the general population. They've done several epidemiological studies. There's been wide variation. However, you will note that it's fairly high. And here, I don't know if you can see this arrow, but 17 to 39% of sample populations based on self-reports or measurements of salivary flow rates either complained of dry mouth and or had a low salivary flow rate. So if you look probably at the weighted average, probably about maybe a quarter of the population has dry mouth for whatever reason. It's more frequent in women, more frequent in Caucasians versus African American, and it increases with age. So how about prevalence of dry mouth in lupus? So there is one study among several that basically find very high levels of dry mouth and salivary dysfunction, and it's 79% of individuals with lupus suffer from hyposalivation. So that would be considered a low salivary flow rate. What we also know is that 20 to 30% of individuals with lupus will have Sjogren's. So three major causes of dry mouth. So it's just not necessarily an autoimmune disease such as Sjogren's disease and lupus. One of the number one causes of dry mouth is the use of medication. So over 1,500 medications have been implicated in causing xerostomia or dry mouth, and 80% of the most commonly prescribed medications have been reported to cause xerostomia or dry mouth. We also know that the more medications you use, the more your salivary flow rate will fall. It almost doesn't matter what the medication is, but the more you use, because sometimes there's interactions that we just don't totally understand. So, what will happen is that many patients who have an autoimmune disease are taking medications that may be causing them dry mouth, in addition to what may be happening with what the autoimmune disease is doing to their secretory glands. And finally, the third major cause of dry mouth or salivary dysfunction is radiation therapy to the head and neck. So those people who have received their radiation therapy to the head and neck, usually for cancer treatment, it knocks out their salivary glands. So the salivary glands no longer work. So why are we so interested in identifying individuals who have dry mouth? The first reason is it's possible to manage this discomfort associated with dry mouth. We are also interested in understanding for those individuals who have dry mouth how to mimic the protective actions of saliva. These individuals are at greater risk for dental decay and oral infections. And there is also a lot more that we can do than, say, 15 to 20 years ago that we can do to prevent dental decay and oral infections. So the bulk of the lecture today will focus on managing this discomfort and understanding how to mimic the protective effects of saliva. And again, this will be a second lecture on Friday addressing the dental decay. We're also interested in knowing which individuals are affected by salivary gland dysfunction because we know a lot more money is spent on, at least in patients with Sjogren's disease, when compared to those individuals who don't have salivary gland dysfunction. So, for example, in 2009, it was $1,400 spent by individuals with Sjogren's versus 503 for normal controls. In 26, it was $2,026, and I'm sure this year this is easily $3,000 or more. Trying to advance. Okay. So first time someone comes into my clinic, I do just a quick evaluation, just a verbal evaluation, determining if someone who has dry mouth actually has low salivary flow. So we're making a distinction here between someone who complains of dry mouth and someone who is lacking saliva. Okay. So in order to determine how someone is lacking saliva, these are actually four questions have been associated with low salivary flow rate. So these first few questions, what happens for the normal person who starts eating is they'll just automatically start salivating. But if you cannot start salivating, you encounter problems with eating, and especially with dry food. So these are specific questions that get at that issue and sort of get at whether or not a person has low salivary flow. So the first of is, do you have difficulty swallowing any foods, and particularly dry foods, such as a cracker? Individuals who don't make saliva, they'll find that they'll chew the cracker will get stuck all over the mouth, and it becomes a real pain to eat a dry food or, dry bread. So they would answer yes to these questions. Again, does your mouth feel dry when eating a meal? Somewhat addressed by this first question, and an individual would answer yes. And do you sip liquids to aid in swallowing of dry foods? Okay, and they will usually answer yes if they have low salivary flow. And this is also a very interesting question, is does the amount of saliva in your mouth seem to be too little, too much, or you don't notice it? So those individuals who have too little saliva tend to also have salivary gland dysfunction. I will also go ahead and measure your salivary flow rate using a Mettler balance, and this involves just simply spitting into a tube in a very defined manner over a very specific amount of time, usually 5 minutes, and we can usually determine your salivary flow rate over a 5-minute period. So just to bring everyone up to speed, I'm just going to refer to the general anatomy of where the major salivary glands are located. So you have 3 sets of major salivary glands, the paired parotid glands, which are located in front of your cheek or in front of your ear in the cheek area. And then you have the submandibular glands underneath your mandible or your lower jaw, and the sublingual glands, which are located underneath your tongue. Keeping that in mind, when we go in and we look at your salivary glands, again, there is the paired parotids, which is located in your cheek area right in front of the ear. There is a duct, if you see this green line, which carries the saliva from the major salivary gland into the oral cavity opposite the first and second molars. So there's a little opening in your cheek where the saliva comes out from your parotid glands. In addition to the parotid glands, there is a submandibular gland and the sublingual gland. Here is the tongue. So this is located underneath the tongue. And this often has a shared duct that exits underneath the tongue via a sublingual or the under the tongue orifice. So we go, and what I do is I milk your salivary glands. So it's sort of like a sweeping motion forward from your ear to the first and second molars. And we're looking at the fluid that's coming out of the parotid glands. Here, this is usually a photo that I could not take because for normal individuals, the saliva immediately disperses. This person has some viscous saliva, so they may be a little dehydrated or they're simply making less saliva. Sometimes we'll see evidence of an oral infection, and this looks like some pus coming out of the parotid glands. And again, here's your first and second molar, and here's the little duct where the saliva is exiting into the oral cavity. This is underneath the tongue, and you see the little glisten of saliva exiting from the submandibular and sublingual glands into the oral cavity. So not all institutions actually can do the saliva salivary flow rate by having you spit into a tube. So some hospitals will use this much more expensive method to measure your salivary flow rate. And essentially they inject you with a radioisotope and they take serial photos. Here we're looking at the uptake of the technetium-99, and this is a specific tracker that goes to your thyroid glands and your salivary glands. And here we see the uptake into the thyroid gland as well as the beginning of the submandibular sublingual glands at 0 to 2 minutes. In this individual, we see the saliva exiting into the oral cavity, okay, at approximately 8 to 10 minutes. So we see uptake by the thyroid, submandibular sublingual glands, and then the parotids, and then exiting of the saliva into the oral cavity at approximately 8 to 10 minutes. So here we have an individual who has low salivary flow rate and likely complains of dry mouth. So you see the tracer being taken up by the thyroid glands at 0 to 2 minutes, at 8 to 10 minutes. Okay, again, very heavy in the thyroid. You see the submandibular uptake, and then you see the parotid uptake. But last time, as you recall in the previous slides, you began to see emptying into the oral cavity of the tracer at 8 to 10 minutes. And here we see beginning at approximately 1 hour. So this person makes very little saliva. Okay, when we look at salivary flow rates in patients with Sjogren's disease, on our y-axis, we have salivary flow rate in millimeters per minute per gland. And on our x-axis, we're looking at parotid and submandibular saliva, so from the cheeks and underneath the tongue. And we're comparing patients with Sjogren's or autoimmune disease versus control. The first thing you will notice is that in our Sjogren's patients with autoimmune disease, there's a clustering of patients with salivary flow rates very close to 0, okay, or unmeasurable salivary flow rate. That's the majority of our patients with Sjogren's, but 20 to 25% of these patients will have salivary flow rates within the normal range. So these are the control patients, okay? And these are patients with Sjogren's syndrome. So some of them will have normal salivary flow rates, but the majority of them will have very low salivary flow rates. Okay, important to note is that the sensation of oral dryness begins when your unstimulated flow rate decreases from 40 to 50% of baseline flow rate. So these are two vases. They're about 2.5 feet high. And this is, you produce probably about 1.5 to 2 liters of saliva for, person who doesn't complain of dry mouth, which will be about here. A person who complains about dry mouth will produce, half of that. So it's approximately here. Okay. And to give context, I have a spoon here, and a patient with Sjogren syndrome who had very low salivary flow rates. If you recall from the previous slide, many of them had very low salivary flow rates. So some of them will only maybe produce maybe 1 to 2 tablespoons a day. So that'd be about what, 10 mLs. Okay. So what happens is, keeping in mind that patients who complain of dry mouth have less saliva, they're producing less saliva, and then our patients with Sjogren syndrome are producing very little saliva. We have to think about the functions of saliva, and they are the preservation, protection, and repair of oral mucosal tissue, has ability to buffer acid, promote remineralization, and prevent demineralization of teeth. And this is referring basically to dental decay in this particular bullet point. Saliva has ability to modulate viral, fungal, and bacterial populations, as well as to facilitate taste. So let's get into, let me see if I can back up. Okay. So one of the first functions is saliva can preserve and repair oral mucosa. We know that saliva is a seral mucus, so kind of thick substance that coats the oral mucosa. It acts as a protective barrier, and there's various components within the saliva that have mucins, proline-rich proteins that are able to help the mucosa repair and are able to bind water to keep the oral tissue lubricated, so there's a nice glide to the oral mucosa. So this is an individual who has an oral fungal infection, angular chylitis. Okay, so cracking, very painful cracking at the corners of the lip, and probably super infection with an antifungal, with a fungal infection. So strategies, okay, if you don't have a lot of saliva, we use oils such as coconut oil or olive oil. We add it to water to help moisturize the oral mucosa. You can rinse with water or a bicarbonate solution to help keep the area as well as the teeth clean, as well as keeping the lips clean and well moisturized. Okay. Saliva plays a very important role in buffering acids. So saliva naturally has a slight alkaline pH, and there's several different buffering systems. Okay, so at high flow, so when you're eating, there's increased bicarbonate, which is a buffering component, and there's increased volume. So there's increased saliva to help wash away debris for increased buffering as well as clearance. At low flow, so these are individuals who have, little saliva, the buffering capacity is at a minimum. So buffering is done by phosphates and histidine-rich proteins, which occur naturally in saliva, and clearance is done primarily by spitting and swallowing. So individuals with low salivary flow rate tend to run a little bit more acid. So what are some strategies that you could use to mimic the buffering qualities of saliva? So one is you minimize the ingestion of sugar and fermentable carbohydrates. You also want to minimize the ingestion of acidic foods, such as carbonated beverages, soda, and wine. Now, if you're going to have sugar or fermentable carbohydrates or have acidic foods, you might want to think about washing away the acidity by rinsing the mouth after the acid exposure. So that can be simple as taking a little cup of, drinking a little sip of water and basically, rinsing your mouth, and then you can just swallow if you're, in a social occasion where you cannot just simply drink some water and spit out. The other thing is important is you can use fluoride to make teeth more resistant to acid, and I'll be talking about this more in my lecture on Friday. And finally, there's some commercial products that are available, such as arginine. Arginine is considered a probiotic. It's a naturally occurring amino acid, which helps make the teeth more resistant to decay. It's currently marketed in terms of, making your teeth more resistant to sensitivity. But what some people are doing is they will mix the arginine containing toothpaste with a fluoride containing toothpaste, or they make sure that they'll use both products in tandem. And also within the dental product line, there's constant change in terms of what's being added or what's being taken away to various dental products. So it's important to read what's in a dental toothpaste or a dental product. And, so things that you're looking for, especially in terms of a toothpaste, fluoride and possibly some arginine. Okay, this is just to emphasize a point, so the intake of various fluids, you have to think about pH when you're ingesting a fluid. So tap water is okay, but there's a lot of sugar-free waters, and especially carbonated beverages, which brings your pH way down to something that's very acidic and which also promotes dental decay. Okay. So saliva, I believe, yes, has antibacterial activity. Basically, there's various molecules within saliva that causes bacteria to clump and prevents adhesion to the dentition and oral soft tissues. It makes it easier to wash away the bacteria. It makes it easier to wash away the food that's in your mouth. There's molecules that help with just straight out killing of the bacteria. The mucins, as we had mentioned earlier, make it more difficult for the bacteria to adhere to your teeth and to your mucosa. And finally, there's lactoferrin, which has a bactericidal effect. So what kind of products or what kind of strategies that you can do to try to get more antibacterial activity within your mouth? Basically hygiene. So make sure you keep your teeth clean. Make sure you rinse out your mouth to keep the mucosa clean as well as the teeth clean. And finally, there is a 0.1%, 2% chlorhexidine oral rinse, which is by prescription, which we give to our patients who have the driest mouths. Okay, how about digestion? So there is salivary amylase along with other enzymes which are located in the mucosa, which helps initiate digestion, starts breaking down the food product. The water or the liquid helps deliver the broken down food products to the taste buds that are located within your tongue. We also have the ability to protect the taste buds by bathing and hydrating them. And basically, you do not want them to dry out. So if you take a little bit of water, before you eat, it can help you with the taste. Okay, so just as a quick review, the saliva has a role in the preservation, protection, and repair of oral mucosal tissues. It has ability to buffer acid, has ability to promote remineralization and prevent demineralization of teeth, has ability to modulate viral, fungal, and bacterial populations, as well as to facilitate taste. Okay, so the oral effects of salivary gland dysfunction is increased caries, mucosal ulceration and damage, increased infections, difficulties with mastication and swallowing, and finally altered speech and taste. Okay, so just a brief overview of managing the sensation of dry mouth. Everybody's different, so everybody will have different personal aggravating factors, but common ones are alcohol, sort of makes the tissues feel kind of dry. Same thing with tobacco. Caffeine, they recommend mainly because of the effect that it can have on dehydration. There's actually a study out of Japan where they find out that certain people actually produce more tears. So we don't know about more saliva, but they produce more tears if they drink caffeine. So some tartar control toothpastes are irritating to individuals, so we recommend going with, as plain a toothpaste as you can get. Mouth breathing, especially while doing athletic activities or at night, if you happen to sleep with your mouth open, can contribute to dry mouth. Liberal use of small sips of water, not drinking a lot of water, which I will mention in the future. It can actually strip off, the protective barrier that's located on your oral mucosa. There's medication substitution in terms of, using a different medication, which has less drying effects, or switching the timing of your medication so that the drying effects secondary to the medication occurs at a time where you're better able to handle it. Often that's at night for some people, and for other people, it's during the day where they can just sip more water. And it's a process of trial and an error. So now we're going to be going over topical comfort agents, masticatory agents, gustatory, which is taste, and finally pharmacologic stimulations, which are primarily pilocarpine, cevimeline, and bethanechol. Okay, so I had sort of alluded to this earlier. A lot of medications are associated with dry mouth. So if you are going to try to manage your dry mouth, looking at what medications you're using, one, can you come off the medication? There's a lot of anti-anxiety medications, which a lot of people take, where I think once you kind of find out what works for you, it's often not a good idea to sort of mess with whatever your protocol is. But you can substitute a similar medication with less drying properties. You can change the timing of the medication, and often, not often, but occasionally we will use a medication to stimulate salivary flow for someone who is having medication-induced side effects. There is a product guide for dry mouth available from the Sjøgren's Foundation. You can look them up online. They're located in Reston, Virginia. Our website is www.sjogrens.org. So they revise this product guideline. It's basically products for dry mouth, products for dry eyes, products for dry vagina, products for dry skin. So this is a really interesting handout. Okay, so let's talk about management of xerostomia or dry mouth. So basically, there are a ton of oral moisturizers and oral salivas, and they're all slightly different. It depends on what your needs are. Everybody has different needs. So if we looked at one product, which is Salise, it has a thickening agent, xanthan gum. And so what that does is it actually makes your saliva a little bit thicker and helps your mucosa glide. It has bicarbonate, which is, of course, for buffering. It has xylitol, let's go back, which is used partially for an anti-caries effect, mainly because the xylitol cannot be metabolized by the bacteria that is associated with causing dental decay. So it's thought that you have this shift in your bacterial population in your oral cavity away from something that is caries causing to less caries causing. Amorphous calcium phosphate is an element that can be in some of these products that helps you remineralize teeth, so it makes your teeth stronger. Types of saliva substitutes. So finding what saliva substitute that works for you it depends on the person. And what it is a trial of trial and error to finding out what works for you. So these are some basic, bases that are used in artificial salivas, carboxymethylcellulose. Then they have carboxymethylcellulose with mucopolysaccharides, glycerate polymer gel. They have mucin-based artificial saliva only available in Europe. Additional components include xylitol, as we had mentioned previously. It inhibits strep mutans. pH should be neutral, Okay, and as we had mentioned why we like neutral in a previous slide, and probably, well, definitely fluoride's probably not an appropriate vehicle. I mean, fluoride probably should not be in these artificial salivas because you're using them constantly. You need to kind of control the amount of fluoride going into your body. So, recommending saliva substitutes. The best products are used mainly for patients with substantial salivary hypofunction. Again, it's a issue of trial and error. None can replace the functional proteins in saliva. It's useful in preventing individuals who get up at night to use the bathroom. The do-it-yourself method, because a lot of these products are $10 a pop. I know people who are going through three tubes in a weekend. So we will suggest a spray bottle, travel spray bottle at bedside, and within that spray bottle, you can use water plus a percentage of oil, and that oil can be olive or coconut. And also you can make and use your own saliva, which I allude to in a further slide. So water tends to be the preferred lubricating agent. But I have alluded to this. You don't want to drink a lot of water because you end up stripping the protective effects or the protective molecules that are located on your mucosa, and you can end up feeling like your mouth is drier. So again, this alludes to it, excessive water consumption. And water consumption at night. We periodically have individuals who are drinking a lot of water at night. They get up, they go to the bathroom, takes them a while to go back to sleep. They wake up with dry mouth. They drink more water. It becomes a vicious cycle and it can contribute to fatigue. Salivary flow stimulation. How are we doing on time?
We're doing well, Dr. Wu.
Okay, I think I might have about 10 more minutes, so
Okay,
to give you an idea.
sounds
Okay,
good.
salivary flow stimulation. So essentially, this is chewing sugar-free hard candies or gums. Okay, so this will sometimes increase individuals who have functioning salivary gland. Their saliva can increase by 2 to 5-fold. Then there is systemic medication, which we'll talk about in greater detail, and then there is self-stimulation. I mentioned this product Xylymel. It's unique for use at night because it is almost like a sugar-free hard candy that sticks on your cheek, adheres to your cheeks by, I guess I want to say suction. I'm not sure if that's the right word, but essentially it allows you to make more saliva at night when you're asleep, and no one that I know of has aspirated this particular piece of hard candy. Okay, so these are a list of very specific chewing gums, sugar-free hard candies. And basically, the fact that they contain xylitol is good, but you can pretty much use any sugar-free hard candy or gum. Medication. So there's two big ones, pilocarpine and cevimeline. These are the standard usages, okay? So 5 milligrams for pilocarpine. They also make a 7.5 milligram tablet. And then there's Evazac, which is a capsule. So there's powder, which you can use also as an oral rinse for those individuals who are not able to take the Evazac. So I had a question about what's the ideal dose for pilocarpine Salogen. So most individuals, that will start them with 5 milligrams, but if they're really petite, I may start them at 2.5 milligrams. When they did the initial trial, they tested anywhere up to 60 milligrams, and they got the best effect at 60 milligrams. But unfortunately, those individuals, while they had a lot of saliva, they had a lot of side effects. So the dose that they eventually chose was 5 milligrams. And basically, what I will do for some of my patients is that we basically titrate the medication. So some patients will need less, some patients will need more. So I hope that answers the questions on what's the ideal dose. Okay, so another comment that I will make about Salogen and Evazac. So usually they'll recommend it taking 3 or 4 times a day. The second comment that I will make is that what happens is you take your pill or your capsule at time 0, you're going to get an increase of saliva, probably within 45 minutes, with you beginning to feel the increase in saliva at approximately 20 minutes. So what I would suggest while you take it 3 or 4 times a day is that you consider, when do you need the saliva? So for most individuals, that's before taking a meal, but you also have to think in terms of, do you need more saliva because maybe you're going out and you're talking with friends, and so you need to have that saliva so you can talk, or you may need the saliva because you're going into a meeting and you're going to be doing a lot of talking. So you need to think about when you need the saliva, and that will dictate when you should take the pill. Okay. So immunomodulatory drugs and dry mouth and Sjogren's disease. So they've looked at a lot of biological modifiers, and they have looked at salivary flow rates, dry mouth. And basically the results have been equivocal, because you would think if you're suppressing the inflammation, if you think you're suppressing the um, immune system, that maybe you would get more saliva. So really, we're not sure. I mean, I've had patients who have told me I took hydroxychloroquine and in 6 weeks I felt great. So it really depends on the patients. And maybe we don't have the ability right now to pick up, that increased saliva that happens after you take an immunosuppressant. Okay, so infections, the most common infection that I see is candidiasis, and it's not the usual white form, white curds, but actually it's the red form of candidiasis. So typically patients who come to me with a fungal infection, their first complaint is burning, okay? And I'll often see the angular cheilitis, cracking at the lips. So not only does the intraoral mouth need to be treated, but the lips need to be treated with an antifungal. These are the medications that we use, okay? So typically we'll go topical. It's more convenient depending on the patient. Sometimes we'll go systemic, but the systemic may not work if a person has really low salivary flow rate, because a lot of times the medication comes out in the saliva. And if you don't have a lot of saliva, you may not be getting optimal delivery of your antifungal. And of course, an antifungal cream for the lips. And I prefer creams over ointments for the lip. Okay, infections associated with dry mouth, especially salivary gland infections. So typically it is antibacterial, and sometimes I will layer in some guaifenesin. And guaifenesin is actually a component of cough syrup. And what it does is it thins the saliva and helps it flow through the salivary glands. The saturated solution of potassium iodide behaves very similar to guaifenesin in the sense that it's a mucolytic agent and it helps thin the saliva. Okay, salivary gland swelling. Typically in our clinic, if there's obstruction, and the typical sign before obstruction is there's pain before eating. So what happens is you may have a stone, a mucus plug, and it's stuck in the duct, and everything backs up behind that plug when you start eating, because you naturally produce more saliva. So, boom. There was a patient who said that they had a stone, and I guess the doctor wants to cut out part of their salivary gland. I think I understood the question, but there are cyanoplasty where they put a scope down your duct, and they can actually have a little basket where they can pull out the stone, or they can use a lithotripsy to try to break up the stone. Again, guaifenesin, Mucinex, which is in Mucinex, it thins the mucosa, okay, which can sometimes help with salivary gland swelling, especially if it's caused by a mucus plug. Massage, okay, to move the saliva through the duct system. So massaging the parotid glands, massaging the submandibular sublingual glands, and of course to stay very well hydrated. Okay, so individualized treatment. depends on the level of salivary gland dysfunction. I think the person who has functioning salivary glands is managed differently from someone who has no functioning salivary glands. Depends on the type of complaint. When are you most dry? Usually, most people have problems only at night. Do they have problems with swallowing? If they have problems with swallowing, then we recommend some water with some oil to sort of moisturize um, your throat. Okay, so as you're drinking your water, you also moisturize your throat with a little bit of oil. The severity of the complaint, are you very dry, kind of dry, you know? Then the next thing is assessment of caries risks, which we'll be talking about on Friday. And it also depends on a time and effort that an individual is willing to expend on oral care and managing expectations. Okay, so management of dry mouth, in summary, you want to keep it simple. What works for one person may not work for another, so it's a process of trial and error. You can consider medication to stimulate saliva, but again, it only works well. It works the best for individuals who have functioning salivary glands, and not everybody does. So again, start with simple measures. Water is usually the lubricant of choice. It is also the most cost-effective one. You can self-stimulate saliva by milking the major salivary glands, pushing on the glands. You can relax. So stimulating the parasympathetic nervous system. So what you can do is you put your chin down and you just relax for a moment and you can feel the saliva coming underneath your tongue. So what you do with that saliva is you don't simply swallow it, but you use it like an artificial saliva to moisturize your palate, your your inner cheeks, okay, wherever you're dry. So that's almost like making your own artificial saliva. And also, in addition to relaxing, you can make sort of a sucking motion with your tongue, which will give you more saliva. So those individuals who can make saliva versus those people who cannot make saliva, the sucking motion can give you the saliva to sort of get you over the hump. And finally, there's artificial salivas and oils, which we had mentioned previously. Okay, so we're coming down the final stretch. Why do we want to identify individuals who have dry mouth? Basically, it's possible to manage the discomfort associated with dry mouth. We're interested in understanding how to mimic the protective effects of saliva. Okay, and finally, these two final issues, the dental decay, we will be managing next Friday. Okay, any questions?
Yes, we do. Thank you so much. That was so helpful.
Welcome.
Such in-depth information. Um, we are getting questions in. So someone, Belinda, asked, I have Sjogren's. I have small bruises on the outside of my cheeks where the parotid glands are. Can you explain why?
Hmm. Bruises, as in discoloration?
Mm-hmm.
That I'm not sure. I don't know if she has swelling of her salivary glands, which can cause bruising. I assume that this area is tender. So I'm wondering if she has some swelling of her salivary glands, which can cause discoloration. Um,
Interesting.
The other thing that can happen, some people will milk their glands, and if you're pushing too hard, of course, that can cause bruising. So the other thing that is associated with discoloration is what I'm thinking of, but it's more of a zebra, is that sometimes tumors, can cause some expansion, which can cause bruising. Because bruising, you think, trauma of some sort.
Mm-hmm.
So that's what I would comment on that.
Interesting. Okay, thank you. Next question, can implants or dentures be done in dry mouths?
So can dentures or implants be done in dry mouth? The answer is yes, definitely implants. I've seen patients with dry mouth who wear dentures, but I think the sort of the trend would be to go to an implant retained denture. So
Mm,
therefore, you have your implants, you have your denture sitting on an implant so it doesn't move around.
interesting. I think the question that we are receiving the most here is what is the best everyday dental routine for a lupus patient? I know you covered some of this with products and with kind of spot treating the symptoms, but is there a specific dental routine daily that you recommend for autoimmune patients that have dry mouth as a symptom?
Yes. So basically, I think the main things are to kind of keep it simple. If you're going to be brushing multiple times a day, you might want to make sure that you're using like an extra soft toothbrush so you don't wear away your teeth. You can, so they have these periodontal toothbrushes, which are ultra soft, and you would buy them online. I'm blanking on the name of them. Um, so definitely use either a fluoride toothpaste and or an arginine containing toothpaste to prevent dental caries.
Right.
And then at a different level, we would use a fluoride containing prescription fluoride. Okay.
Okay.
Especially if your dentist feels or you feel that you're at high risk for dental decay.
Okay. Sounds great. What causes dry mouth in lupus and Sjogren's? And how are they connected?
Okay. So let's just say, at least in Sjogren's disease, the autoimmune disease affects the secretory glands. So it causes them not to work anymore. And what happens in lupus, we think the same process is going on. Maybe an autoimmune process where the secretory glands are affected because it might be kind of, now we're beginning to think of autoimmune disease as a continuum
Mm-hmm.
where people will have, autoimmune disease, but different, organ systems are affected. So what happens is they're actually not sure what's causing, the dry mouth, but they do know that the acinar cells, which is the cells that produce the saliva, are not working. And it may be because of an autoantibody or the body is attacking in some way the an element within the salivary gland.
Okay. You answered this a little bit already, this question, but does dry mouth affect your digestion, swallowing, or taste? I think you've already kind of touched on this quite a
Yeah,
bit.
I have sort of touched on it. And taste is very, very complicated. A lot of times the most common thing or the most common happening that I will see in my clinic is a fungal infection where
Mm,
the infection basically wipes out the taste buds
oh my
and,
gosh.
and actually the patient will look like they have a bald tongue. And so we can actually, get their taste back by treating the fungal infection.
Wow, that's crazy. Um, it looks like our next question is, are products for your oral microbiome like mints or gums bad in lupus patients? Are you familiar with those products?
So
I think they're referring to like probiotic, like oral probiotic
yes,
products, I think.
so we pretty much know that the microbiome of an individual with an autoimmune disease is going to be different from someone who doesn't have autoimmune disease.
Hmm.
Which particular bacteria is, important or not important, especially in the oral cavity. They're just beginning to do that work probably within the last 5 to 10 years. So I think that everything in moderation, it's not I wouldn't say it's a definite, but I'd say it's not a bad idea.
Okay.
For example, the arginine that I mentioned is considered like a prebiotic, which sort
Okay.
of, and xylitol would also be considered sort of a biotic.
Interesting. Okay, thank you. Do you like the product Cloisis for gum health? Are you familiar with that product?
Yes, I am. Yes, so it's a nice adjunct to use, and basically your dentist can identify whether or not that process or that particular product is good for you. So Closest makes a bunch of products for dry mouth, and pretty much they, hit the major targets in terms of what you're looking for, a product for dry mouth.
Hmm, okay, great. If you are found to have multiple cavitations on a head CT, should you have them removed? And could removing them possibly improve autoimmune symptoms? Is that something that you have experience with?
I'm not sure when they say cavitation, I don't know if they can ask their question, but wasn't sure if they're referring to dental decay
I think
or,
so. I think
or
so.
so you don't necessarily want to you do want to remove the dental decay because it's a source of infection in your mouth. You don't necessarily have to remove the teeth. So that was something that I didn't quite understand about the question.
Okay. I'm trying to see what else we have here. I think you answered a lot of these in your talk already about products, mouthwashes, toothpaste. You were super thorough on that front, which was great. When should we see a dentist or specialist for our dry mouth symptoms? And this is from a lupus patient.
Uh, you can, I think, whenever you're having a problem. So I can only speak for my particular clinic. Basically, we stratify where you fall in terms of your salivary flow, what your problems are in terms of discomfort, and we send you out with sort of personalized regimen. And I don't really need to see you again, except for maybe in a couple years, because every couple years new products come out, new ideas come out in terms of managing dry mouth.
Okay.
I should also um, mention that it is a process of figuring out what works for you. So tell me the question again. How often should you see the doctor for dry mouth?
Oh, when should you see a dentist if you
Ah,
have dry mouth?
so I think if you're having a problem and
Okay.
you're not able to work it out by yourself.
Okay. That makes sense. I think our last question here is if you have dry eye and dry mouth, does that usually mean that you're going to have other glands involved with problems in the body? I think that's probably case specific, but do you have any thoughts, Dr. Wu?
So there are individuals who only complain of dry eyes and dry mouth and seem to be okay in terms of the rest of their symptoms.
Okay.
But, then there are people who have dry eyes and dry mouth who have other organ systems involved. So it depends.
Okay. Well, thank you so much. This was so helpful. We're grateful to have you to here today.
You're most welcome. Pleasure.
Um, just for everyone listening, our next session today will be at 3 p.m. So if you're a caregiver or if you know someone who is, this session will be for you. It's called Caregiver Wellness, Managing Emotional Fatigue and Preventing Burnout with clinical psychologist Dr. Monica Blyde. And then this Friday, we'll have Dr. Wu back to talk about tooth decay, which we're excited about. So if you want to join that session or have more questions for Dr. Wu between now and then, we'll be happy to answer them in that next session on Friday. Thank you so much again. We really appreciate your time.
My pleasure.